Yes, we are on live.
Yeah. So welcome to this fourth edition of COVID education series organized by Heartfulness in collaboration with Medicover Hospitals and American Association of Physicians of India. I welcome all viewers for today's session, which is on antithrombotic therapy in COVID scenario. So what evidence says? We have been seeing last 1.5 years when COVID came. Initially, we thought of only, it's a severe acute respiratory syndrome, but subsequently enough data built on thrombotic episodes on venous side, thrombotic episodes on arterial side. And when the protection for COVID came, that is in the form of vaccines. After vaccination, we have seen patients ending up in thrombotic episodes. So this thrombosis events in COVID are becoming more and more common, and every physician has to know about it. So, and I welcome all for today's episode, and I invite Dr. Gansham to introduce our panel and then speaker and then move on.
Thank you, Sharath. I think we have a brief presentation by Dr. Mukharjee, who is a senior interventional cardiologist and one of the few guys who has read extensively and followed COVID. I think he has read more about COVID than most of the treating COVID doctors. And for the panel, we have Dr. Professor Rupen Arya, who is a professor of thrombosis and hemostasis, King's College Hospital. He is the national lead for VTE and the national director for the National VTE Exemplars, London. Dr. Deepak Govil, who is the director of critical care and anesthesia from Medanta, New Delhi, and he is also the president of the Indian Society of Critical Care Medicine. He's going to join us a little late. We have with us Dr. Haresh Mehta, the senior interventional cardiologist and the founding director of Healing Hearts, Mumbai. Dr. Ganesh Jaishetwar, who is a hemato-oncologist, a senior consultant and head of bone marrow transplant and hematology from Yashoda Hospital, Secunderabad. And Dr. Manish Bharti, who has been there with us since the start of this webinar, a very dynamic consultant, intensive care specialist from Prince Sultan Cardiac Research Center, Saudi Arabia. Over to Dr. Mukherjee.
Thank you, Dr. Gansham. I'd like to add a small correction to the introduction that you gave me. I'm also treating some of the COVID patients. So, okay, I'm sharing my screen. Can you see my screen?
No, not yet.
Yet. Okay.
Okay. Technical thing. Yeah. Okay. Right.
Now you can see?
Yes.
Okay. Yeah. Now, we'll start with this program. This is quite a challenging topic for me. Antithrombotic things in COVID.
Dr. Mukherjee, sorry to interrupt you. Can you just put it on this slideshow because your screen is only half visible?
No, I did put on the slideshow.
It's cool.
Perhaps it is taking some time to show, but it is on stage.
It is in the slideshow mode. So.
In the slideshow mode, yes. Okay. This is a challenging topic because most of the treatments that have been advocated for COVID-19 have been put under a scanner. Let us say steroids, let us say remdesivir, let us say tocilizumab, sarlizumab. You take any medicine that has been put under a real scanner, but not for the antithrombotics. Everyone has taken it for granted that antithrombotics are indicated in COVID-19, and then everyone is giving them. So now what are we going to learn today? These are some of the questions that we'll be trying to answer today. Is the thrombosis risk more with COVID? Is there definite evidence, or is it all anecdotal? And then how is this different from hospitalized non-COVID patients? Let us say any patient who is admitted in an ICU carries some increased risk of thrombosis. Is it the same, or do COVID-19 patients have increased risk? And does it make sense to start anticoagulation If we start anticoagulation, when do we start it? Before, during, or after admission? And then when do we start anticoagulation? For mild disease, moderate disease, severe disease, or critical disease? And at what dose shall we start? What dose shall we continue it? And then shall we do it a therapeutic anticoagulation or a prophylactic anticoagulation? If we decide on a prophylactic anticoagulation, do we need to give a standard dose or an intermediate dose? And which agent to use? Do we use heparin? Do we use fondaparinol? Or do we have to use Dovax or Novax? And what about the antithrombotics after discharge? How many days should we give? What is the dose that we should give? And then what about the antiplatelets during or after COVID? These are all some of the interesting things. And then when I present this, I'll present it in a temporal fashion. That means as the evidence has unfolded during the COVID treatment, we'll try to capture this sense how doctors are trying to answer these questions. The first and foremost thing that we are going to answer today is COVID definitely increases the risk of thrombosis. This is a meta-analysis in which it has been found that the venous thromboembolic episode risk is 14.1% for the COVID-19 patients, whereas it is only 0.3 to 0.1% for symptomatic VTEs in non-COVID patients. This is non-COVID patients, sorry. And then if you take ultrasound studies, COVID-19 patients have shown that almost 40.3% venous thromboembolic risk. Whereas for non-COVID patients, even those who are admitted, the chance is 2.8 to 5.6% overall. This is a non-COVID patient, so I'm sorry for the typo. And then we have all seen this kind of things. So many case studies. One of my patients who is around 56-year-old, previously was on anticoagulants, had COVID, we monitored him, we treated him, we discharged him on anticoagulation. He developed a brainstem thrombosis and died the next day, once we discharged him. This angiogram that you are seeing on the left side is of my patient who is 38-year-old. And then who was discharged from COVID treatment 1 week ago from another hospital. He landed with an acute anterval MI. When I did an angiogram, this is the thrombus, smooth vessels, but intense clotting that we see. And then if you see on the right side, you have a 21-year-old lady who has a thrombosis in the proximal LAD. And these things are happening. A lot of patients have pulmonary embolism. Just now, one intensivist was talking to me, and then he told me that they are doing a follow-up CT scans after 10 days or after some time in the ICCU. And then when I are sending for the CT scan, they're also asking for a CT pulmonary angio, and they are finding the asymptomatic pulmonary embolism in almost 10% of these individuals. Huge. So definitely COVID causes an increased thromboembolic risk. This is a slide which tells you that the thrombocytopenia is unusual in COVID-19 sepsis when we compare with other sepsis, and D-dimers are mostly elevated in COVID sepsis, apart from the conventional sepsis. And then we have also seen that a lot of autopsy studies were done, which have revealed that there is a definite thrombosis in whatever tissue studied in COVID-19, especially the pulmonary tissue. So thrombosis is definitely elevated. This was in April 2020 in European Heart Journal, and this is what they have advocated. You take all the patients with COVID-19 symptoms. If there is a high-risk thromboembolism, especially if they're admitted to an intensive care unit, you either start a heparin drip or you start enoxaparin 1 mg per kg per BD. Or if there is a low risk of thromboembolism, if the D-dimer is elevated, again start enoxaparin 1 mg per kg twice daily. If the risk is intermediate, you start enoxaparin 40 milligrams twice daily. If the risk is very low, then you start enoxaparin 40 milligrams daily. This is what they have advised in April 2020. All of the temporal events. This is in April 2020. And then slowly, the antithrombotic science in COVID-19 has progressed. This is in July. Mount Sinai study, this was in New York, they have done a study on 2,773 patients. And then what they have found out is, in patients requiring mechanical ventilation, in-hospital mortality was better with therapeutic anticoagulation. That means the mortality was 62.7% in those people who did not receive therapeutic anticoagulation. And then longer duration of anticoagulation is associated with reduced mortality. This is the first positive trial that has come, which has told that therapeutic anticoagulation is good, and then it has come from Mount Sinai School of Medicine. You see this is the slide that I put up. You see the all patients, 2,773 patients. You see the red line in whom the therapeutic anticoagulation was given, and in blue line there is no therapeutic anticoagulation is given, and the survival probability is quite high in the red line. That means in people who have received therapeutic anticoagulation. And then even the same thing happened in patients with on ventilator. This is when was this? This is in July. And then we came to September 2020. September 2020 in thrombosis research, this is one more study which has shown, this is called a HESA-COVID study. And then it's a phase 2 trial. What they have done, they have taken 10 patients requiring randomized it to therapeutic anticoagulation versus prophylactic anticoagulation. And then they have shown that the PaO2 by FiO2 has increased with therapeutic anticoagulation from 163 to 261 over 14 days. That's huge. Whereas with prophylactic anticoagulation, the PaO2 by FiO2 has started from 184 to 195. But this is a small study, mind you, only 10 patients were studied, but this is a hypothesis generating study, we should say. And this is the slide for that. And then there is a prophylactic anticoagulation, there is no benefit. With the therapeutic anticoagulation, there is benefit in terms of PaO2 by FiO2 ratios improving. And then the American Journal of Hepatology, this is in January 2021. In-hospital aspirin compared to no antiplatelet therapy was associated with lower cumulative incidence of in-hospital death. You see, there are two arms to this study. This is published in American Journal of Hematology. One is an aspirin trial, and another is an intermediate dose anticoagulation. And then the aspirin has shown that it is beneficial in that it has got a reduced in-hospital mortality. And similarly, intermediate dose anticoagulation. Now, I'll simplify this for you. If we are talking about a prophylactic dose anticoagulation, we are talking about 40 milligrams of enoxaparin per day. When we are talking about intermediate dose anticoagulation, we are talking about 40 milligrams twice daily of enoxaparin. When we are talking about therapeutic anticoagulation, we are talking about 1 milligram per kg of enoxaparin twice daily. That's what we are talking about. And in the same study, it was shown that the intermediate compared to the prophylactic dose anticoagulation was also associated with lower cumulative mortality. And in February 2021, NIH has given some guidelines. What they have told is, in non-hospitalized patients, there is no data to support measures of coagulation. That means in non-hospitalized patients, for all the patients, you don't have to routinely monitor D-dimers. That's what is the updated guideline from NIH. This guideline stands even today. That we have to understand. The hospitalized adult should receive prophylactic dose of anticoagulation. There is a benefit given to that prophylactic dose of anticoagulation. And discharge anticoagulation can be considered for those with high risk of venous thromboembolism and low risk of bleeding. This we'll have to understand. And then incidence of venous thromboembolism, what they have told, is 14.1% with COVID versus 5.6% in non-COVID hospitalized patients. And in critical non-COVID patients, it's around 16%, whereas critically ill sepsis patients, it is 37%. This is NIH recommendation, mind you. Pre-hospital, there is no anticoagulation, no monitoring for anticoagulation. Within the hospital, prophylactic anticoagulation, there is no benefit of therapeutic anticoagulation. That is the guideline up to February 2021. And then discharge anticoagulation may be considered if a patient is having increased risk of venous thromboembolism and a reduced risk of bleeding. Then came February. In February 2021, you have a French cohort study. Okay. In French cohort study, 2,878 patients were studied, and then 382 of them were treated with oral anticoagulation before admission. And then people who were treated with oral anticoagulation before admission for whatever reason, they were having a better prognosis. This is a French cohort study. This was published in JAHA in February 2021. Okay, so what they say is use of oral anticoagulation was associated with less ICU treatment or composite of ICCU and death. Okay, this is pre-hospitalization anticoagulation. Okay, this is for whatever reason. This anticoagulation was not started for COVID-19. You'll have to remember that. This anticoagulation was started for some other reason, and they have taken these patients, and then they have measured that that these people are doing better than people who did not receive an anticoagulation before hospitalization. Okay, this is a French cohort study, and we are into March now. Now this is a fundamental. There is a very important trial has come here. This is a composite trial of REMAP-CAP, Active4A, and ATTACK study. These three trials combined together they have formulated the data, and then they have released the data in two installments. This is the first installment, which has come in March 12th, 2021. And then this is a preprint, mind you. They did not publish it in the journal. What they said, they compared is between therapeutic anticoagulation versus prophylactic anticoagulation in critically ill patients. And then they have found out that the probability of futility of approach with the therapeutic anticoagulation is 99.8%. This is a well-designed study, mind you, and this is a very accepted study, very high quality data. And then what we have found is that therapeutic anticoagulation is futile in these patients. This is the graph that they have shown, and then these orange and green curves are almost overlapping. That means that there is no mortality benefit with therapeutic anticoagulation in the composite of these three trials. And then we are still in March, and then Inspiration randomized control trial has come. In Inspiration randomized control trial, it has compared intermediate prophylactic anticoagulation versus standard prophylaxis. Standard prophylaxis is around 40 milligrams per day. And intermediate dose prophylactic anticoagulation is 40 milligrams twice daily of enoxaparin. And then there is no significant difference in venous arterial thrombosis or ECMO need for mortality. In 562 patients, the primary outcome is not different in between these two. And then the severe thrombocytopenia in 6 of intermediate group and none with standard group. What they have found out is there is no difference between intermediate dose prophylactic anticoagulation with standard prophylaxis of anticoagulation. And then they said prophylactic anticoagulation is sufficient for these patients. This is Inspiration trial. Okay, this is what is standard dose enoxaparin and intermediate dose enoxaparin. Intermediate dose enoxaparin is not helpful. They have also added the therapeutic dose of enoxaparin also in the same study along with the intermediate dose. Okay, next, there is a review article which was published in a postgraduate medical journal in March itself. And then what they have told is parenteral anticoagulation indicated in any acutely ill hospitalized patients. And then in moderate cases, enoxaparin 40 milligrams OD is indicated. And in severe critical patients, enoxaparin 40 milligrams twice daily is indicated. This is a consensus opinion that they have put forward. This is not a original article, mind you. This is a review article. And then what they have told is diagnosed or suspected macrothrombus if it is there, then you use therapeutic anticoagulation with enoxaparin 1 milligrams per kg twice daily. And then what they have suggested is post-discharge prophylaxis is indicated when the score is, the VTE score risk is more than 4, or when it is more than 2 with D-dimer of twice normal, or if the age is 75, or if the age is more than 60 with D-dimer twice normal, or 40 to 60 with D-dimer twice the normal with the history of the venous thromboembolism. I'll come back to that slide later. And then in April, in chest, the French ICU study was published. What they have told is the high-dose prophylactic anticoagulation is better. And then they have told that the reduced thrombotic complications in the critically ill. What they have mentioned is critically ill, high dose prophylactic anticoagulation is better. This goes against the REMAP-CAP or ATTACK and this composite trial. And there is no increased risk of hemorrhage. This is just an observational study, mind you. And high dose includes both intermediate and therapeutic dose. And then what happened is in French ICUs, initially one kind of a treatment was given, prophylactic treatment was given. After that, they have changed it to high dose. That's why they could compare both these trials, both these approaches. And then what they have told is significant reduced risk with high dose with a hazard ratio of 0.81. And pulmonary embolism, DVT, and catheter thrombosis are the main events in that. And 7% of the people had bleeding complications. And I think I'm confusing you enough, but I'll slowly unravel what is happening. And by the time Inspiration 90-day follow-up has come, this was published again in April 2021. And Inspiration, the 30-day trial was initially given, and now 90-day follow-up, there is no benefit again of intermediate dose heparin when compared to standard dose. Again, a lot of confusion. Is the prophylactic dose better? Is the intermediate dose better? Or is the treatment therapeutic dose better? Now comes REMAP-CAP Active 4A and ATTACK trial, another preprint. This is a good platform and a very good data. And now they have come up with a positive trial. If you remember in March, they have given a negative trial saying that therapeutic anticoagulation doesn't work in critically ill patients. Now come May, in 17th May, they have given another data set in which they have studied 2,219 non-critically ill patients, and they have shown that the probability of superiority of therapeutic anticoagulation in these patients is 97.3. So, and then 92.9% in low D-dimer group. So in high D-dimer group as well as in low D-dimer group, they have proven that it is almost certain that therapeutic anticoagulation will help in moderately ill patients, non-critically ill patients. In critically ill patients, the same group has shown that there is no mortality or no benefit, and the probability of futility is above 90% with therapeutic anticoagulation. What they have postulated is possibly if the critically ill patients are too far downhill, and perhaps even therapeutic anticoagulation or whatever may not help in those patients. But in non-critically ill patients, perhaps this thing is helpful. That's what they have told. Major bleeding is 1.9% in therapeutic anticoagulation versus 0.9% with prophylactic anticoagulation, and therapeutic anticoagulation increases the probability of survival to hospital discharge. And major thrombotic event or death occurred in 8% of therapeutic anticoagulation and 9.9%, roughly 10% of prophylactic anticoagulation. This is another positive trial that has come in May. And then you see the possibility of superiority is 99%. And then with the mechanically support or respiratory support or death also, it is definitely therapeutic anticoagulation. They have shown that it is superior. And action trial was there in ACC 2021. They have submitted this data. And then today in Lancet, it was published. Why I am saying today in Lancet it is published is the science of antithrombotics in COVID-19 is so rapidly evolving that if you blink, if you have not updated yourself over last 24 hours, you must have missed the Lancet article. And action trial has shown that therapeutic dose of rivaroxaban or 1 mg per kg of enoxaparin for unstable patients did not help. This was presented in ACC 2021. And then the primary outcome is mortality, duration of hospitalization, and duration of oxygen use. And primary outcome is 34.8 versus 41.3 for therapeutic anticoagulation versus prophylactic anticoagulation, which is not statistically significant. And then all-cause mortality is probably slightly higher in therapeutic anticoagulation rather than prophylactic anticoagulation. And it reduced DVT and increased bleeding as expected in the therapeutic anticoagulation group. Okay, the components of primary outcome in these are the mortality, duration of hospitalization, and oxygen use. And overall, therapeutic anticoagulation did not help. In May 2021, Annals of Internal Medicine, another trial, Stop COVID analysis. This is important. 3,239 critically ill patients have been studied. 6.3 had venous thromboembolism, 2.8% developed bleeding. And then patients with early therapeutic anticoagulation had similar mortality as the rest of them. Only around 12% of the people were given therapeutic anticoagulation, and these patients did not fare better than the rest. So that is what it is. So even if you start the therapeutic anticoagulation early, they did not show a benefit in these patients. But mind you, the positive results are in non-critical patients, in those patients in whom therapeutic anticoagulation is given, they have shown improved survival. The American Society of Hematology guidelines, this is an old one. This is in October 2020. And then what they have recommended is in favor of prophylactic anticoagulation over intermediate intensity or therapeutic intensity anticoagulation. And for patients with COVID-related critical illness or acute illness who do not have confirmed or suspected VTE, again, prophylactic intensity anticoagulation only. This is American Society of Hematology guidelines. And this is 2021, in May 2021 in blood. This is very important, mind you, in Core 19 registry. This is about thromboprophylaxis for after discharge, post-discharge thrombotic antithrombosis. Okay, in 4,096 patients, thromboprophylactic was given in 13.2% of the patients, and post-discharge anticoagulation was significantly associated with the reduction in primary outcome. And the primary outcome was the composite of venous thromboembolic episodes, arterial thromboembolic episodes, and all-cause mortality. So definitely in those people who are at an increased risk, the prophylactic anticoagulation post-discharge is helping these people. Post-discharge anticoagulation reduced the risk by 46%. 46%. So we have to give post-discharge prophylaxis depending upon the Core 19 registry. How long do we have to give post-discharge prophylaxis? In Core 19, they have studied a prophylaxis of 30 days. 30 days is what they have studied. How do they predict increased risk? Increased risk is predicted by advanced age, more than 75 years. People with cardiovascular risk factors, like people who have had stroke, who have had MI, who have had unstable angina, or in patients with CKD, in patients with improved DDVT risk of more than 4, and then in people who have had ICCU stay. These are the people who are going to be benefited with prophylactic anticoagulation. And this is how they said venous thromboembolism is around 1.55% post-discharge. Arterial thromboembolism is 1.7%. So what we are seeing perhaps is similar, though we tend to remember the cases in whom the coagulation has come. We will not remember the 98 to 99% of the people in whom there is no anticoagulation. So the all-cause mortality because of thrombosis post-discharge is 4.82% in Core 19. Okay, and this is the risk calculator, improve the VTE risk calculator. We can use this. This involves prior episodes of thromboembolism, thrombophilia, and paralysis of lower extremity during hospitalization, concurrent malignancy or immobilization, ICCU admission, age more than 60 years in this, and D-dimer more than 2 times the upper normal. That's why it is called improved DD. DD is the D-dimer. So, okay, overall improved DD score, if it is more than 4, that puts them at an increased risk. So, ladies and gentlemen, if you are listening carefully, there is still more to be unraveled about the antithrombotic treatment in COVID-19. What we have known so far is that the patient group is really heterogeneous, and then we cannot make recommendations as a blanket for all the COVID patients who are admitted, for all the COVID patients who are moderately ill, for all the patients who are critically ill also. We cannot put them all together and give a single guideline. If the guideline has to be given, a single guideline has to be given. These are so many guidelines you see here. You see the CDC guidelines, you see the ISTH, you see the ACP guidelines, you see the ASH guidelines, you see the SCC guidelines, you see the ACC guidelines, ACCP guidelines, so many guidelines. And whenever you see so many guidelines, you can be assured of one certain thing, that we have not understood the disease or the complication or the treatment fully. What we have to do, however, at this point of time is to give prophylactic anticoagulation for those who are admitted, and to go on to therapeutic anticoagulation for those who are moderately ill and for those who have increased risk of venous thromboembolism. Perhaps try to avoid therapeutic anticoagulation in those who are critically ill, and then post-discharge, you identify people who are at an increased risk of thrombotic episodes, and then you treat them with an extended doses of anticoagulation. This, ladies and gentlemen, is the take home today. Thank you so much for a patient hearing.
Thank you, Dr. Mukherjee. I think you have kind of taken us beautifully to the sequence of evidence that came, and I totally agree with you. I mean, the kind of benefit that was documented in the initial stages with therapeutic anticoagulation, probably the recent recommendations are against it. However, I totally agree with you that there's a lot of still doubts, confusions, and some kind of uncertainty as to what exactly would be the ideal dosing schedule. May I request all the panelists to join me, and Dr. Mukherjee would also be one of the panelists. I would like to take his opinions as well. Dr. Professor Arya, when I joined intensive care, I mean, the role of D-dimer was very, very limited. In the sense, the only thing that I could remember was to do it in the lowest probable risk of PT patients to rule out or rule in pulmonary embolism. But the way we are following D-dimer so extensively today, probably the number of times the D-dimer is being done for a COVID patient, do you think that we are justified in chasing D-dimers? Or
well,
does it have any the numbers have any correlation between the severity, or does it influence our dosing strategies?
Yeah. So thanks for inviting me to join today, and thank you, Dr. Mukherjee, for your very interesting talk. These have been extraordinary times, and I think certainly in Western healthcare, it's been like the Wild West. People have taken COVID as an excuse to really stretch the boundaries beyond the evidence. And it also depends on the personality of the carers. Some people feel more heroic, when the results are tweeted, they adopt the results and translate them into practice. Others want to wait for the full paper and examine the data. So these have been very challenging times, and indeed, one of my talks, I call it building the plane while flying it, So I think there's a lot of this that is very controversial. I certainly agree with a lot of what Dr. Mukherjee said, but with some aspects, there's less agreement in the practice. And in D-dimers, I think, we went completely wild, because the ISTH guidelines last year, said that the coagulopathy is predictive of worse outcomes. There were a couple of small biased Chinese studies that suggested improvement in survival in people with high D-dimers. And so as a result, certainly in London, we ran out of D-dimer kits. But now I think if we pull back and look at it a little more rationally, there's very little evidence to support the use of D-dimers on a routine basis. I think we can certainly do a D-dimer if a patient with COVID is ill enough to be admitted to hospital. I know in India, people are testing D-dimer in the community and anticoagulating in the community, which is absolutely wrong. So certainly on admission to hospital, and maybe in critical care, there's a case to be made for repeating it on a daily or alternate daily basis, because it gives us a handle on the progress of the patient. And indeed, sometimes, if there's a sudden jump in the D-dimer and the patient has become more difficult to ventilate, it might raise the suspicion of pulmonary embolism. But certainly, I think there's no evidence whatsoever to support the use of D-dimer to stratify the intensity of the anticoagulation, nor is evidence from RCTs to support the use of D-dimer in anticoagulating people on discharge from hospital. So really, I think we must limit our use of D-dimers. Yes, there's a role, but it is a limited role.
Yeah, I totally agree with you, because even in our hospital at a point of time we had to run out of the D-dimer kits. Dr. Deepak Govil.
Yeah.
Sir, welcome. Sir, with respect to the dosing of anticoagulation, yes, there has been a lot of ups and downs. Initially there was some evidence to suggest that therapeutic anticoagulation in the critically ill patient probably has a mortality benefit, but as Dr. Mukherjee has presented the REMAP ACTA, the recent trials are suggesting that probably the benefit is not so much in the critically ill patients as compared to the moderately ill patients. Some kind of a paradox there. Your thoughts on that, sir?
No, I agree that in critically ill patient, the earlier evidence was to give therapeutic anticoagulation, but majority of the cases we are not using therapeutic anticoagulation. Only, as Dr. Rupen has said, a patient who's on ventilator suddenly starts deteriorating. At that point of time, we may think to give a higher dose of anticoagulation, but majority of the cases are on prophylaxis dose. What we have just made a trade-off that in the prophylaxis, we are going slightly on upper side rather than a middle or lower side. I don't know what I'm doing is right or wrong, but that's what I'm doing.
Any thoughts from the other panelists? Any comments and opinions on that?
The higher dose is intermediate dose, and then perhaps there is not a robust evidence even in favor of that also. The evidence is more in favor of a prophylactic dose anticoagulation only. But like I have said, it is changing every day. It's really challenging to keep up, let alone treat these patients.
So one question with respect to the mortality, if you keep the mortality benefits separately, now we are looking at a lot of other thrombotic complications, not the VT, but the higher incidence of myocardial infarctions, the higher incidence of cerebral strokes. Does it make any difference with a higher dose of anticoagulation in this group of patients? In the ICU, we are seeing patients who have come to the hospital and then develop a stroke, or then develop a cerebral venous sinus thrombosis or an MI. So, we have looked at data only with respect to mortality or with respect to the venous thromboembolism. But do we have something to suggest that probably the incidence of strokes is or any other thrombotic incidences is better with a higher dose of anticoagulation?
In majority of these trials, even arterial thromboembolism also was studied. It's not only the venous thromboembolism. And then if there was a survival benefit, it will be more because of arterial thromboembolic episodes rather than venous thromboembolic episodes. If you take off venous thromboembolic episodes, and if you take only the pulmonary embolism and arterial thromboembolic episodes, then mortality difference will definitely come in. And even that evidence has not been there anywhere, because these events are not much different even with the therapeutic anticoagulation in critically ill patients. But again, perhaps like you said, if you take these arterial thromboembolic episodes separately, perhaps we can glean much about it.
Dr. Harish, your thoughts, I mean, from the cardiac perspective.
Yeah, actually we've seen quite a few young infarcts post-COVID, during COVID, with large amount of thrombus. And although we don't have evidence of benefit with oral anticoagulation, in such patients, we do give them oral anticoagulation. I don't know how right or how wrong we are, because we don't want to lose young patients like these. In fact, I had another interesting observation about D-dimer, in a non-hospitalized patient. Suppose you have a young non-hospitalized patient. We have seen quite a few. So on day 2, day 3, they are doing okay. And day 5, day 6, their oxygen is okay, but their D-dimer is sky high. And these are probably some of the ones who go down rapidly and need admission and also die. So maybe D-dimer was a prognostic marker there to suggest that they should be in hospital soon. I would want the thoughts of the thought leaders of this.
Professor Arya, your thoughts on this?
No, that is, I get WhatsApp messages from India on a daily basis that people are serially measuring D-dimer in their mildly affected relatives sat at home. It's quite interesting for me because now I know that everyone with COVID has high D-dimers, whether mild or moderate or whatever. And the moment the D-dimer and the CRP comes up as raised, the relative is usually, not hypoxic and often very mildly affected. They want to start them on anticoagulation. Now, there might be a role for this, as indicated by one of the trials that Dr. Mukherjee presented. But I don't think there is any RCT evidence, and there's no convincing data out there to guide our practice. And given that the modality of treatment, which is full anticoagulation, has a finite risk of bleeding, I would hesitate to do it routinely. Yeah.
No. Dr. Deepak, I mean,
what I was saying is just as Professor Arya has rightly said, my whole contention is that D-dimer is one of the inflammatory markers. So we should not take it D-dimer as a separate entity. It should be taken as in toto, as a inflammatory marker, as a marker of something going wrong in the coagulation profile as well. So sometime it could be possible that D-dimer, high D-dimer is indicating the more of the pro-inflammatory state rather than a problem in the coagulation state.
Yeah, actually that's exactly I was asking, that should we use D-dimer in a non-hospitalized patient to determine hospitalization? That's exactly what I wanted to know.
The guideline is definitely against this, Dr.
So I just want to take the opinion of the other panelists, Dr. Ganesh and Dr. Manish. Then I'll come back to the same question in a different way. Dr. Ganesh.
Thank you for this opportunity. So, from a perspective, looking at
Dr. Ganesh, we are losing your volume.
Sir,
Yeah.
am I audible, sir, now?
Yes, better. But
my apologies, sir. Technically.
Yeah.
Okay. So, okay. Then I hope I'm audible now. Hello.
Some disturbance. Yes.
Yeah. So, sir, from hematological perspective, looking at the literature evidence and a small number of patients at our institutional experience, beyond just coagulopathy or micro as well as microvascular thrombosis, COVID-19, the major blunder effect on lungs is on the vasculature, so mostly microvascular. So, and looking at the evidence, beyond DDM, I just wanted to ask also on this August platform, how many of your patients do as those requiring ICU hospitalization or those with moderate to severe degree of COVID-19 illness, how many of you routinely do you check for the routine Dopplers and pulmonary CTPA. So if you look for it, going by the literature, the incidence of occult thrombosis in the.
I think we've lost. Manish, you are around here?
Yeah.
Manish,
am I audible?
Yes.
Yeah. Good evening to everyone. Thank you, Dr. Mukherjee, for an excellent presentation. Although, I missed a substantial part, so maybe I can review it later on. I've listened with, a lot of interest with whatever the Professor Rupin Arya and Dr. Deepak Gogal has said. Dr. Ghanshyam, what we understand that whenever we receive the patient from the intensive care standpoint of view, we start the person onto the intermediate dosing regimen, because obviously we are not going to receive the patient who is having a mild illness, right? So majority of the patient, they will come into the category who are definitely having a moderately severe, the category of, the hypoxemic respiratory failure. When we do so, at the same time, we make a lot of effort to understand, the data in integration with, the clinical presentation of the case. For example, that, what we do, we must scan the patient for the right-sided the pressures, the right side heart pressures. We assess the patient whether the patient is having any acute cor pulmonale or not. Not only this, we also assess whether the patient is having any significant elevation in the stretch or injury markers of the heart. So what we are basically trying to do, Dr. Ghanshyam, that we try to integrate, all these variables, which we have, the data from, the COVID-19 studies, along with the European Society Cardiology recommendations. And in case if we find that the patient is having even a submassive presentation of embolism, see, the data is very clear when it comes to the macrothrombosis and the DVT. Nobody is having a doubt with respect to, that kind of, the clinical presentation. The whole data is basically confusing with respect to when you have not so very clean picture with respect to, that you're not having certainly the diagnosis of macrothrombosis per se. So let's say that, if you find that the patient is having any significant elevation in the stretch and the injury markers of, the myocardium, in that kind of a subset of the population, we generally try to be liberal in terms of giving them, the therapeutic anticoagulation. And, having said so, we have, learned a lot data which Dr. Mukherjee has made a presentation. And I must acknowledge this fact that, whatever has been the data, we have not seen any fatal complication as far as, the therapeutic anticoagulation is considered. So because we need to understand, the patient is having a multiple risk factors, not only apart from the COVID-19, the patient has a lot of risk factors to have, highly prothrombotic.
Manish, okay, we are just trying to discuss or, unravel the role of D-dimers in an outpatient setting. So I just want to rephrase the whole thing to the entire panel, including Dr. Professor Arya, whatever Dr. Haresh Mehta said. Now, if you have a patient who is probably a diabetic, a middle-aged, has a inherently higher risk profile for a thrombotic event, and he has an elevated D-dimer, still not been hospitalized, will it make a difference in interpreting those D-dimers as compared to a young patient, non-diabetic, but has a higher D-dimer? Professor Arya?
I don't think we know the answer to that. And, we know, for example, from the multi-platform studies, REMAP-CAP, that D-dimers were not very helpful for risk stratification in the different arms that were anticoagulated. So there are no RCTs to guide our practice, in which case it is an unknown. And I think the intervention, which is full anticoagulation, is not without risk. So really, I'm afraid I am very cautious and conservative in that setting. And I would certainly hesitate before, starting to anticoagulate people at home on the basis of a D-dimer. I think the only useful measure, at home to guide admission or not is pulse oximetry. If the oxygen drops, then, it's a good idea to seek medical attention in the hospital setting. But, people are sending me IL-6 and CRP and, D-dimer combinations done on a daily basis. It's interesting that how commonly all these things are raised in COVID. I think that it reveals to me. But I don't think we have the evidence to be able to discriminate between your elderly, obese, diabetic, as opposed to your younger patient on that basis.
Okay.
And that patient will have a higher bleeding risk as well, the older patient. So I think, I don't think there's the information out there that has been published to help guide our practice.
I'll just take this opportunity to welcome Dr. Anupama, who is the president of AAPI. Welcome, madam. Just taking the discussion further, is there any role for antiplatelets? Just like we have been talking about, anticoagulation at home front. Do you think that there is a role for antiplatelets in this population? Or is it the same? Like if I have a diabetic patient, diabetic, hypertensive, elderly, as most of the general practice is to put them on antiplatelets for prevention of thrombotic events, especially the coronary or the neurological. Do you think that if a patient was not on antiplatelets, would you initiate antiplatelets in these patients? Dr. Mukherjee, Dr. Arya, Dr. Haresh.
I stand the risk of being a bit of a broken record, but there is an RCT that is shortly due to report. The REMAP-CAP have recruited over 1,000 patients to the antiplatelet study. So I think we should have an answer soon. And I think it's highly likely, given that we see platelet hyperreactivity, that antiplatelets will have a benefit. And Dr. Mukherjee indeed presented a paper from earlier this year that suggested that, but I don't think we have RCT data at the moment. Yeah.
Dr. Mukherjee, Dr. Harish, as cardiologists, one of your favorite drugs is antiplatelets. So would this be a reason to put patients on antiplatelets?
I do put them because I don't think I lose much by putting them. So I do put them on aspirin for sure. Although the evidence is very mild, as he showed in one trial that aspirin did slightly better than the others. I'm sure the other trial which Dr. is talking about is going to be positive.
No,
Dr. Mukherjee?
One particular trial has shown definitely the benefit of aspirin in admitted patients. Definitely there was some improvement in the overall primary outcome of the trial. This was published in January.
No, I just wanted one simple answer. Would you put your patients on antiplatelets?
Yeah, if they have a low bleeding risk, yes.
Okay, so on an outpatient basis, still probably,
no. On an outpatient basis, no, absolutely not.
Irrespective of the risk profile of the patient.
Yeah, see, for that, I'd like to answer it in a roundabout way. We have found out that in patients with diabetes, with risk factors, aspirin plays no prophylactic role. So there is no prophylactic aspirin in high risk of people who have high risk for cardiovascular events. So aspirin prophylaxis, even for COVID patients, non-admitted patients, I wouldn't suggest it routinely, no.
Dr. Deepak, Dr. Manish, taking that discussion a little further, in the intensive care unit, now there was one of the papers where Dr. Mukherjee said that when the antiplatelets was added to anticoagulation, there was certain benefit. So what are your thoughts when the patient comes to the intensive care unit? Would you club anticoagulation with an antiplatelet agent? Deepak sir and Manish. Deepak sir, आप म्यूट पे हो.
No, I'm sorry. I just reached home and there is a lot of noise, so I moved from one room to another. So what I do, if the platelets are okay in the number, probably more than 2 lakhs of each patient, so we give antiplatelet to majority of the patients along with the prophylactic dose of anticoagulation.
So when I say
antiplatelet,
ecosprin,
can't say
ecosprin, isn't it, sir?
Right or wrong, but that's how I do.
Manish?
Ecosprin 75 milligram OD, that's it. And majority of these on discharge also I recommend.
Manish, your thoughts?
Yeah. Again, Ghanshyam, I would like to say that unless and until there is a specific contraindication for the patient not to be on antiplatelets, by and large, they receive, the prophylactic dose, 75 milligram of ecosprin. So, you have to see the reason why they cannot be given. So in case if they can qualify because there is no contraindication, they need to be on both the antiplatelet as well as anticoagulation.
So I think most of the panel agrees to the idea that starting anticoagulation at home probably is not a good idea or is not something which is backed by solid evidence, right? Now, just want to know, does your anticoagulation strategy differ in the wards if the patient is on oxygen, low flow oxygen versus high flow oxygen? Say somebody who's on about 2 to 4 liters versus somebody who's on about 10 to 12 liters. Does the anticoagulation strategy differ or would it be the same? Professor Arya.
Yeah, I think this, what's clear from the studies is that, our traditional one-size-fits-all anticoagulation approach probably needs to be a little more nuanced in the setting of COVID because it seems to be the thrombotic risk seems to be proportionate to the degree of inflammation, but the bleeding risk is also proportionate to the degree of inflammation, which is probably why the patients on critical care have higher rates of alveolar hemorrhage, which was one of the main increases in major bleeding in the REMAP-CAP studies, for example. So at the moment, I think the only thing that the existing evidence safely tells us is that all patients who are ill enough to be admitted to hospital with COVID should at least be on the standard dose of anticoagulation for prophylaxis, adjusted for weight and the renal function. Because I think there are a lot of limitations with the existing studies. We last summer increased the anticoagulation dose in the critical care patients to like 40 BD, which is an intermediate dose of anticoagulation. And the reason we did that is that we had a 16% symptomatic pulmonary embolism rate despite the use of standard prophylaxis. So that's why the NICE guidance also changed. Now the question is, do we have enough evidence on the basis of the multi-platform studies to alter that practice, of stopping using intermediate dose because of remap cap? But the trouble with remap cap is that the critical care part of it was comparing therapeutic dose anticoagulation to standard of care. And standard of care in the majority of those patients, in 51% of the patients, was actually intermediate dose anticoagulation. So we do not currently have the evidence to inform that decision, because the only existing RCT is Inspiration, which was a study done in Iran and was really underpowered to ask the question that, intermediate dose versus standard dose, because the numbers were not high enough. And certainly the patients, if you look at the tables, are not recognizable to me, at least, as being our typical critical care patients, in that the length of stay was 5 days and the VTA rate was 3%, Nowhere in any of the studies is the VTA rate on prophylaxis in a critical care patient less than 10%. So Inspiration, to my mind, is a flawed study. So there's no information out there to help me guide my decision to stop using intermediate dose on critical care at the moment. So I would give the ASH guidelines and many of the other guidelines say use standard dose thromboprophylaxis all the way through. Again, Dr. Mukharjee presented the remap cap, which suggests that when patients are admitted to the ward, they should be put on full treatment dose. Now, that is something, I had in January 11 wards full of COVID. It fills me with fear, Many of these patients are elderly patients. And the interesting thing about remap cap is that VT was never an outcome, The outcome is organ support free days. So what they have shown is a 4.5% adjusted absolute improvement in the need for organ support, So what that means is that maybe the patient might have one less day on CPAP and one more day on low flow oxygen on the ward, The number needed to treat to improve survival is over 100. So my personal view is to use standard dose prophylaxis adjusted for the body weight and renal function. And in the critical care patients who are still having a lot of clots, my practice, and it is the one part in which I do depart from the evidence, is to use 40 BD of enoxaparin instead of 40 once a day. But I certainly would be very fearful of anticoagulating every single patient on the ward fully, as some people have suggested after remap cap. And indeed, our NICE guidance has also changed, so no one is following it.
Deepak sir, Manish, you both would agree with us, but in the initial part of the pandemic, when the pandemic started, in the intensive care unit, at least, I was using a therapeutic dose of anticoagulation. Now, it's a little, little scary or kind of a fear that if we scale down, the incidence of bleeding that I have found in my own unit has been significantly less or not. I don't recollect any major bleeding that is happening. Do you think it's safe enough for us to go back to a standard dose or an intermediate dose as compared to therapeutic dose in the critically ill patients? Deepak sir, Manish?
Honestly, as I shared that I am using the what you say, intermediate or the prophylaxis dose. Only in few patients we are using therapeutic dose. So coming back to me is already we have come back. What my personal perspective is, I maybe differ from the other August gathering, that last year we saw more of the strokes and more of the cardiac complications. This year we didn't saw that many. This year the ventilatory complications are too high, too many patients on the ventilator. I was looking after almost similar set of the number of the total ICU patients last year, but this year there was a phenomenal increase in the ventilated patients, and other complications like AKI, like stroke, cardiac problems were much less this year. I don't know what is the reason. It could be a just coincidence at my center, or it could be a generalized phenomenon.
So what is the dose that you're using, sir? 40,
Yeah,
40 or BD?
We are using majority of time a prophylaxis dose and sometime intermediate dose.
Okay.
And
okay.
if we feel, as Professor Arya has said, if we feel that there is a clotting tendency, or many times the staff says that the moment we are taking out sample, it is clotting. In such patients, we are going therapeutic dose, but that is very anecdotal. I should not quote it here, but that's what we are doing. And in those patients where we feel that suddenly ventilator parameters has changed, oxygenation part has changed, without altering their compliance, in those patients, we are also giving therapeutic doses.
Manish.
Sir, can I, Dr. Ganesh here?
Yeah,
Ganesh.
Dr. Ganesh,
point,
please,
from a hematological perspective,
yes.
Most of the points are well taken, sir. So, most important for our subset of patients, of course, this may not be relevant to international guidelines. We have seen many of the mildest infections getting admitted out of sheer apprehension and fear. So those mild infections without any respiratory support, I think the anticoagulation guidelines, the jury is not out. So probably they can be, they are not the candidates for the, whatever kind of anticoagulation. Some kind of anticoagulation, as highlighted by various guidelines as well as ASH, is of paramount importance. Those with significant, high flow oxygen or on mechanical ventilation, or those whose the lung parameters are worsening within 48, 72 hours, definitely therapeutic anticoagulation, which needs to be extended just like for any unprovoked DVTP. And with regard to antiplatelets, of course, as all our eminent panelists have described, there is no clear-cut guideline, but the patient's underlying comorbidities and the various critical illness scores can be, something which can help us, because we have seen many patients. And one important point I wanted to highlight here is those patients worsening beyond just COVID lung disease. We don't think of, the worsening, the PT and the microangiopathy. In fact, COVID beyond the thrombopathy is also vasculopathy. So putting all these factors together, of course, intermediate and therapeutic dose anticoagulation jury is still not out, but for critically ill COVID-19 patients, at least intermediate dose anticoagulation, and not a standard anticoagulation for all hospitalized patients in our subset of patients, because I'm sure all of us who are treating in India will agree that almost 25-30% are mildest of the infections who have just got admitted out of fear and just apprehension. Thank you.
Manish, you did mention the use of biomarkers for helping your antithrombotic dosings. So do you mean to say that you track troponins or BNPs?
Yeah. See, Ghanshyam, see, we have to understand that, the COVID is not a disorder of solely the ventilation. There is definitely a perfusion effect which is happening. And especially when the patient is coming, early in the course of the disease, when the patient is not having too much of, the problems with respect to, the secondary component of sepsis and all, there the perfusion component is playing a significant important role. So this is what, I was trying to say, that when the patient is coming, early in the course of the illness and the patient is having a refractory hypoxemia, there's no doubt that the patient has to receive at least a standardized prophylactic dose regimen to start with. Now, depending upon, the workup which we have to demonstrate, whether you find that the patient is having some evidence of, acute cor pulmonale, and, we have been following up all this kind of cases where we have shown that, the patients are having some form of, either a change in the stretch markers or the injury markers on the right side of the heart. So, you just finding, the answers to this given solution on the basis of solely COVID-19, I think it may be injustice at this point of a time. As Professor Rupanari has clearly said, there are a lot of, the data which is still, is going to accumulate over the period of time. So you have to fit your patient COVID-19 into a situation where the patient is also having, other, the organ dysfunction, which has to be taken into the account. In that kind of a situation, Ghanshyam, if the patient is showing, the injury markers positive, yes, I change the patient from, from prophylactic to maybe a therapeutic regimen as well. And as you have said, and this is my observation also, Ghanshyam, that we have not seen any kind of, a significant bleeding complication. So this specifically becomes important, Ghanshyam, in cases where there is no significant defects in the ventilation. You have done, the scans, you realize that the patient is still refractorily hypoxemic, and the only plausible explanation in that given situation is maybe related to, the thrombi burden.
Yeah.
So in that kind of a situation, have taken this kind of, the call. Otherwise, at least as, Dr. Mukherjee has said, and Harish has also said, at least, they should need to be on intermediate regimen in case the patient is critically ill. Otherwise, the standard dose of, the prophylactic.
Professor Arya, Dr. Mukherjee, and Dr. Harish, your thoughts on the use of biomarkers. Do you think that there is a scope for biomarkers, which can help us in, in having some kind of, or identifying those patients who should be on therapeutic dosing?
No, I think as Dr. Manish said, in your critical care patients, the biomarkers are just one part of a jigsaw that is helping you to judge what is going on in patients who are often on the ventilator, so they're not able to tell you what's going on. So I think you have to take all the signals, if they get more difficult to ventilate, looking at the right ventricle with an echo, using the troponin, and jumps in D-dimer as well. So we are looking at the whole patient, and all these signals help kind of combine to give us an answer. I know there was early on in COVID a lot of enthusiasm for thrombolizing patients as well. Again,
I was about to come to that.
We have drawn back to that, and our criteria for thrombolizing is the same as they've always been.
Actually, that was part of the whole discussion. I was about to take you there, because one of the major things which has been put forth in the pathophysiology of COVID is the segmental and the subsegmental thrombi. And doing a CTPA on a sick ventilated patient is very, very difficult. So do you see any role of thrombolysis or half dose thrombolysis, which was, kind of a concept which was put forth in patients where there is sudden drop in saturations unexplained on the ventilator? Dr. Mukherjee, Dr. Harish.
Yeah, you said, you asked about the biomarkers also.
Yes.
Biomarkers, we are definitely getting guided by the biomarkers. There is no doubt about it. And in fact, what we see is a lot of patients with heart failure with preserved ejection fraction. We are seeing a lot of such patients with raised BNP levels, with a normal LV on echo. We are seeing a lot of patients like that. And then by necessity, we are getting guided by biomarkers every day. But what unfortunately it is doing is that it is blunting our clinical skills. We are not following them as clinically we used to follow them. We are depending more on the biomarkers, which I wouldn't advise. We have to combine these two data to get to a point where we can treat them better. That is something that is important. As far as the thrombolytic is concerned, just because the saturation has come down and then there is an evidence of pulmonary embolism, we don't have to thrombolize them. We can just do a echocardiogram at the bedside. If you see that the pulmonary arterial pressure has suddenly gone up, or if you see that there is a jump in D-dimer, if you see that the RA and RV are dilated and the pressure is falling, then perhaps you can take it as a high degree of suspicion for pulmonary embolism and then thrombolize. If like Professor Arya said, the indication for thrombolysis is the same. If you have a shock or if you have an RV dysfunction in the setting of a suspected pulmonary embolism, even if you are not able to do a pulmonary scan, perhaps you can go ahead and thrombolize, and not without that. Not just because we are suspecting that COVID-19 is a thrombotic disease of subsegmental pulmonary arteries. And because of that, perhaps if we give a half dose lytic, perhaps they'll become better. There is no evidence absolutely whatsoever to think like that.
Dr. Harish, your thoughts on the same?
Yeah, so on the biomarkers, I mean, is really misleading because troponins will rise despite not having an MI. So you have to evaluate the clinical situation. troponin, BNP all tells you these are poor prognostic markers. But if you have a clear-cut ECG evidence of an MI, then you're justified in either taking him to the cath lab or a thrombolysis. But at the same time, seeing his COVID status. So if you take a very severe COVID patient on ventilator for thrombolysis or a primary PCI, he's not going to make it either ways. So those patients you neither thrombolize nor do you do a PCI. So you have to divide your patient as per previously only. As again, Dr. Arya had very clearly said, it doesn't change. It just gives you prognosis that this patient is going to do worse compared to the non-biomarker patient. And then all your things together will work as you normally do. So treat COVID as any other disease and treat the biomarkers as a prognostic marker. That's how I see it. But I still want an answer to my question. Nobody's answered that to me. The D-dimer rising in a non-admitted patient, can it be a marker to admit him that he's going to go down with his lungs?
I think Dr. Arya did suggest that probably there's not much of evidence to suggest just an elevation in D-dimer as an indication. He would still go with oxygenation. He would still go with what is happening with the pulse oximeter and see whether the oxygen levels are going down or not. Am I right, Dr. Arya?
The reason I asked this is that I've been managing lots of my family members actually. We have about hundreds of them. So most of these guys who had sudden very high D-dimers and CRPs, they suddenly went down. They had to be admitted in emergency. I have no evidence in favor or against. I just wanted more opinion of people who have seen more such cases.
Can I say something?
Sorry.
Can I say?
Ghanshyam? Yeah, Manish. Is it okay? Please.
Yeah, I agree with Harsh. The problem is that Ghanshyam, we need to understand that somewhere he's giving us the pinch that do we have any way to assess that the patient has a possibility of going into a cytokine storm. So basically, somewhere, the Harsh is trying to rationalize that, on the basis of some biomarkers and some form of a clinical assessment, if you can put this data together into a one kind of format. And yes, if you remember, Ghanshyam, we had a discussion in, the previous seminar that the Temple University from USA, they came out with, the predictive scoring system for CRS. Yes. So that kind of a scoring system, yes. If you discount the patient on the basis of on the basis of, the clinical things and, not taking the biomarkers, I think, again, it's an integration of, both the things. And what I normally do, Ghanshyam, with respect to the biomarkers, the previous question which you have asked, I always place my patient into some form of organ functional assessment assay. So there has to be some kind of a baseline Apache scoring or maybe a SOFA scoring for the patient. And if you find that the patient is having a high score, where the chances of, the imminent morbidity and mortality is high, and plus the biomarkers, they are relatively high. These are the kind of cases where the biomarkers has to be taken very, very sensitively, not in isolation. They cannot be.
But unfortunately, Manish, if you see in the recent second wave, you find a lot of youngsters where the Apache scoring may not be very high. We have seen a lot of youngsters landing up with severe COVID and losing their lives. And if you go by the Apache in these subset of patients, probably the Apache scorings will not be very high.
That's why I'm saying that, the kind of, the assessment, Ghanshyam, there has to be some form of an assessment. I agree that, the Apache and SOFA may not be able to replicate, especially for the young population. But still, if you see the by and large majority of the population, which are elderly, coming with, the high-risk morbidities, comorbidities and all, still it can give you, it can fetch you, some answer to this given, the enigmatic situation. So yes.
Professor Arya, your comments on what Dr. Harish Mehta put forth, saying that
no, I completely share his concerns. In fact, we published our data in nearly 2,000 patients quite early on last year, and overall, I think 5% of our COVID patients had pulmonary emboli, and 16% on critical care, about 4% on the ward. And those that were diagnosed on the ward were, the majority of them were diagnosed with symptomatic P within 48 hours of admission, which suggests to me some of them had pulmonary embolism in the community, quite a substantial proportion. But still, that does not indicate to me that having tested a D-dimer, in the UK, you have had to be pretty unwell to be admitted to hospital. You can't be admitted because you're a celebrity with a positive test or because you can afford a bed, Here you had to be really on your knees to get into hospital either on the wards or in critical care. And I think the symptoms are the main judge of that. Either someone is managing at home or they're not. And yes, there's a subset that the people in ED are not sure whether they need admission or not. They get given a pulse oximeter and sent home and say, okay, if the readings go down, come back, we'll admit you. Yeah. I think there's nothing like good old-fashioned clinical, pragmatism and sense.
Yeah, Dr. Mukherjee, you wanted to say something? Dr. Mukherjee.
See, what Dr. Harish has suggested is really interesting. Like, what I would look at is if all the markers are increasing, like you said, the D dimer, the CRP, if most of the markers are increasing, there is a high likelihood that the patient may land in a storm, or definitely a progression of lung disease can be predicted. But if the D dimer alone is rising, which is it is in some patients, and all the other markers are normal, D dimer alone is increasing, then we have a patient population who are coming to me with D dimers. They are saying that my D dimer is 490 today, yesterday it was 430, please admit me. These are the kind of population we are facing now. And it is very difficult to make them understand that both 430 and 490 are normal, please go home. They are not able to understand that. So once we have an isolated elevation of D dimer, what I am trying to do is, if it is significantly elevated, let us say above 4 times the upper normal limits, if it is elevated to that extent, what I'm doing is I'm investigating them for any thrombosis which is underlying. Maybe it is also not according to the guidelines. But if I'm trying to see that and then following up that, but admission-wise, the criteria remain the same. Admission-wise, if the saturation is falling, then we'll admit it. That will.
My fear is it is sometimes, we are extending beyond the boundaries of what the evidence tells us. And, because the D dimer is going to go up, which it probably is in all patients with COVID, because, we don't test people with flu at home for D dimers. If we check D dimers, it'll be up, So does that mean you should be putting them on anticoagulation? Does it mean you need to be putting them on steroids? And then, the whole, and we know what happened with the steroid story. So I'm call me old-fashioned, but
before I move on to the before I move to the next final question, I just want to take the opinion of Dr. Deepak Govil. Sir, I mean, the question of thrombolytics. In an intensive care unit, you put patients on the ventilator, everything is going well. Suddenly, you find that there is a sudden drop in saturation of the carbon dioxide going up. I mean, you can't take the patient for a pulmonary angio or CTPA. Would you recommend a thrombolytic just based on a sudden change in the gas exchange if you have ruled out the other causes?
No, not at all. At this point, I'll highly depend on the echocardiography. I'll look at the right heart, what is the situation at the right heart. But in a patient who is having COPD or ARDS, their right heart pressures can be raised at the baseline only. But majority of the patients who are coming to the ICU, if they are on ventilator, even if they are not on ventilator, one basic scanning has already been done. So our team is doing scanning regularly. So once the basic scanning is being done, and now after 1 day or 2 days, there is a sudden change in oxygenation. So somebody would have picked up easily on the basic first initial, not basic, what I would say the initial assessment. So if initial assessment, the right heart is okay, and now one's feeling that right side is dilated, grossly dilated, and patient is going into shock and hypotension, then one can think of giving thrombolysis. But in corona patients who are already on intermediate dose or full therapeutic dose of anticoagulation, what we'll do is little difficult to say.
Okay.
Like if I'm giving enoxaparin 40 BD and top of that thrombolysis, it's a little difficult for me to accept that.
One question does one agent have or better than any other agent? For example, is it enoxaparin versus heparin versus fondaparinux? I mean,
my choice is very simple. Enoxaparin is there, and in patients who are having renal failure, we change it, and those patients who are having Low platelets, again, we change to another molecule. That's it. That's the preference.
So finally, thoughts
Professor
from all
Arya, what is your take on this? Both the questions. Like both.
I completely agree with you, Deepak. That the choice of anticoagulant in the hospitalized patient certainly should be low liquid heparin, whichever one you use. And there are many reasons for that. One is the short half-life. The other is it is the anticoagulant with the fewest drug interactions. The third is the anticoagulant that we are most used to as well. And it's parenteral rather than oral. So at least, the absorption is good. So yes, I would agree with you. Yeah.
So finally, what would be your discharge advice? Would you put patients on, anticoagulation on discharge, and what determines which patient gets a post-discharge, advice on anticoagulation?
So is that to me or
to all the panelists? But we'll start with Dr. Arya.
Yeah, I don't want to monopolize the conversation, but yeah, I mean, my own practice, and given everything I've said so far, it probably would not surprise you, is that I strongly advise against routine use of post-discharge prophylaxis, because there still might be a role for selected patients. If someone has got cancer and has had recent admission with COVID, if they've got a previous history of major venous thromboembolism and they're still not completely mobile, then on a case-by-case basis, I might, but I would not routinely give prophylaxis. Now, there's two reasons for that. One is there's ample epidemiology, including, I think the first paper was from my group last August or September, in a group of 2,000 patients who had been hospitalized with COVID, and we did not show that post-discharge VT was increased compared to other medical patients. The second is that there's no RCT data. The third is that hitherto we have never believed that the evidence on medical thromboprophylaxis was strong enough to respond to. It's in none of the guidelines, because the number needed to treat from Mariner, Magellan, all the studies, APEX study, the number needed to treat is 233, to cause a small benefit. So if the medical thromboprophylaxis data hitherto has not been strong enough to give post-discharge prophylaxis, and there's no new RCT data, and our epidemiological data and that of others shows that post-discharge VT is not a big issue, so I would not use it. And Dr. Mukharjee, I think, presented the Coalition Action Study, which was published today in the Lancet, which was 30 days of rivaroxaban or enoxaparin while they were an inpatient, but discharged, so that their full 30 days of anticoagulation was of no benefit in reducing VT, but increased the bleeding. So I rest my case.
Just extending that question, does oxygen dependence at discharge influence this decision? Because that could limit the mobility in a higher risk patient. So does that have an influence on the decision?
Yeah, no, that is a question to which I don't have an answer, and I've been in numerous heated discussions with, because we have in London quite commonly a model called hospital at home, in that we have been discharging people with home oxygen, and some people believe they should be treated exactly the same as if they were in hospital. But others say that if they're improved enough to go home, then where is the evidence to give them prophylaxis? So here I think it's 50-50. I'm willing to go either way, but I won't do it. Yeah.
So Mukherjee, your thoughts?
Yeah, like Professor Arya said, the evidence from the trial that is published in Lancet today, definitely there is no benefit, and then increased risk of bleeding is there. But Core 19 registry has shown some benefit in certain patients post-discharge who can be benefited with anticoagulation. perhaps those people who have an increased VTE risk can be identified, and then they can be treated with anticoagulation. That's my take on that. I am going to select patients, and I've been selecting patients who have an increased risk of thrombosis and who have a reduced risk of bleeding or less risk of bleeding. And I am placing them on anticoagulation. And I am slightly more aggressive than Professor Arya.
Manish.
Yeah,
Yes, Manish.
See, Kansham, I understand with all respect that, the data which Professor Rupanarya and Dr. Mukherjee is talking about. See, we also need to understand, Kansham, that, our patient discharge criteria is very different from, what we replicate in the Western models. Here, we are dealing with a situation where the patient are facing a crisis for the admission as well as for the discharge as well. So many of the patients, they will be prematurely discharged, given the fact that you have to give the beds and allocate to many other, the sickest of the patients. So in that kind of a scenario, I don't know whether you can exactly replicate, the model to our, the subset of population. So our patients are relatively different in terms of, how we are managing given the crisis situation, given the pandemic situation. So I think exactly replicating the data from the Western subject may not be the justice to our patients. So you may have to, modify according to the sickness criteria.
Dr. Harish.
Yeah, I mean, I agree. I wouldn't send them on any oral anticoagulation unless there is compelling evidence. So you have to have a clear compelling evidence. Like Dr. Arya said, we've not been sending patients on oral anticoagulation. In fact, we've been discontinuing patients who have been sent on oral anticoagulation home.
Deepak sir, your thoughts?
Same as most of the panelists, I am not sending any patient to home on oral anticoagulants, but certainly those patients who are on home therapy oxygen, and I feel that their mobility is too restricted, maximum to maximum going to toilet, on them we are giving low molecular weight heparin as a prophylaxis. And in a follow-up, when we feel that now they are mobile enough, then we discontinue it and just continue maybe with the ecosprin for some time.
Dr. Ganesh, are you there? I think we don't have. If I just have to summarize for the benefit of the audience, I think most of the panelists agree that currently probably the standard or the prophylactic dose is what is recommended. Therapeutic dosing, if you identify patients who are at a high risk, or if there is some evidence of venous thromboembolism or a thrombotic event, then probably those are the subsets of patients where therapeutic anticoagulation would be needed in the hospitalized patient. No roll-off or may not be the ideal way to follow D-dimers routinely. Probably not much of evidence to say that. However, I mean, if you have a parallel rise in all other inflammatory markers, then probably those are the subset of patients where you probably have to keep a close watch. Antiplatelets, I think some of the panelists had probably didn't find it harmful to start a small dose of ecosprin, and most of us would do. And at discharge, most of you agree that probably not much of evidence. You need to individualize, identify those subset of patients probably who would be at a very, very high risk of thrombotic events. For example, patients with malignancies, patients with previous history of venous thromboembolism, or as Dr. Deepak said, if they are on oxygen and has a very, very limited mobility with a, probably somebody with a very high body mass index would also may fall in that category. These are the subset of patients where you may have to think of post-discharge anticoagulation. Dr. Chandrasekhar, would you want to say anything?
Yeah, thank you. Thank you, Dr. Mukherjee and all the panelists. This is a very, very, interesting topic. And still it's evolving, as Dr. Mukherjee has mentioned. And, as an internist practicing general internal medicine, I always remember these guidelines are there to help us to treat the patients. But, we have to individualize the treatment, use our, the art of practicing medicine, and they use some of our intuition. So a lot of times we get a feel, okay, this patient is not going to do well. Those are the patients that we want to extend our guidelines, go beyond the guidelines and do what is necessary for that individual patient. And again, I want to thank all the panelists and the nice presentation, Dr. Mukherjee. Thank you. Good to see you again. I hope you remembered you came to some of our COVID meetings a few months ago. And thank you, Haresh and Dr. Deepak and Dr. Professor Arya. Thank you for taking time. And most importantly, the one thing that these three great organizations come together. Our Heartfulness Institute, they've been doing an extremely good job in the last 1 year, providing the, starting from basic support to the COVID victims at home, giving them the Heartfulness has delivered millions of meals free of cost to all the COVID victims, some of the migrant workers in the last 1 year. And we have a team support groups. we formed support groups where we have the volunteers, doctors came together and helping to assist the people to be treated at home, giving them the emotional support, medical support. And now we are in this, in this drive to initiate the vaccination for all the people, several cities in India. So the collaboration between the doctors, the volunteers, and the hospitals, which we are seeing here, and the spiritual organizations like the Heartfulness Institute, our Medicare hospital, and the good organization like AAPI, Physicians Organization, we're all coming together to bring the awareness and to help each other in this pandemic. I hope we all will continue to do this. Next Wednesday, we have a good presentation about oxygen delivery. Again, we are going to talk about what are the, how we want to focus on bringing the awareness to the people at home, the patients, the caregivers, the volunteers, the families, and, for the house staff and internists treating the patients in the wards, and for a little bit about the ICU. We don't need much education for the intensivists, but there will be an interesting topic next Wednesday. All of you, please join. Thank you.
Thank you, Dr. Arya, so much. Thank you so much for taking your valuable time. Deepak sir, thank you so much. Dr. Mukherjee, always a pleasure hearing you. Thank you, Dr. Haresh. Manish, you have been there with us since the start. Thank you so much for being there with us. Thank you, Anusha. Thank you, Abhirami. Thank you, Dr. Chandrasekhar. Thank you, and